Welcome to EASL Studio, your weekly hepatology broadcast news. Today we'll discuss resmetirom. I think it's a breakthrough. It's a result of decades of research. For the first time, we have a drug on the market. But we want to use this episode also in the honor and as a tribute to Stephen Harrison, who suddenly recently died. He's been a pioneer in the field and actually led much of the research around resmetirom. And he lived to see it was approved, and he was very happy about that. And I think also for this, discussing this in his honor is a privilege for all of us. With me today, I have Naim Alkhouri, who was a very close associate and friend with Stephen. He's from US, and Amalia Gastaldelli from Italy, and Sven from Antwerp, all closely related also to Stephen. So maybe I can open up with you, Naim. How big is this? And also, what was Stephen's role in bringing this as the first drug to the market?
Thank you so much for having me, and thank you for saying a few words about my dear friend, mentor, and role model, Dr. Stephen Harrison. Stephen really took resmetirom to the finish line. He was the lead PI for the entire program. He was the first author on the Maestro-NAFLD paper that was published in Nature Medicine, first author on the Maestro-NASH paper that was published in the New England Journal of Medicine. A true gentleman and a scholar. He would be dearly missed by all of us. No one knew more about resmetirom than Stephen. And as you mentioned, I'm happy that he at least saw it get FDA approved. And we will continue his legacy. But he's done so much to get resmetirom to FDA approval.
So, and I think we're very lucky to have you step in. Actually, he should have been here and talked a little bit about it. Sven, from your point of view, also worked a lot with the drug development. How, I don't know, it's difficult for researchers to see, but how big is it actually to get a drug on the market? You wrote an editorial about the graveyard of all the drugs that didn't make it.
Well, there are obviously several hurdles to that, which are related, amongst others, to the way the endpoints are defined. But we have witnessed indeed a lot of phase 2 and even phase 3 trials that failed. Probably part of the issue is about the endpoints, but also probably that some of the drugs were not powerful enough. And here, after so many drugs that failed, or studies that failed, we have a drug that hit the endpoints, high barrier endpoints that were agreed upon with the regulatory authority. So this is really a breakthrough. We have now an anti-NASH, specific anti-NASH treatment in phase 3, approved by at least one of the big regulatory authorities in the world. So that's really a game changer. You cannot tell anymore what sometimes is argued, that we don't have a treatment for NASH, so or for MASH we should not look for it because we can't do anything about it. We could already do something, that's true, but now we also have a specific drug and there is more to come. So this is really changing the whole field. It also creates a lot of enthusiasm in the field to continue to develop even better drugs, or drugs for those that are non-responders to one drug. So it's really, yeah, it's fueling the field, and it creates a lot of enthusiasm and ambience. It's a real game changer.
So, Amalia, breakthrough, game changers. Is the same kind of word you would use, or where you?
No, actually, I will use the same words. And I think it's also very interesting because it's not only related to the liver fibrosis and the NASH. It will have a big impact probably also on cardiovascular disease, because the effect on lipids in peripheral are very strong. So I'm assuming that in the future, when we will have a result of a long study for safety and the cardiovascular effects, this will probably have, we'll see major protection against other comorbidities related to NASH, because we know that cardiovascular disease is a major comorbidity in subjects that have NASH.
Oh, very good. I'll come back to that a little bit later, but maybe first, Naim, I would like to ask you, for those who don't know the New England paper by heart, but what if the effect size? Can you do it in maybe an absolute term for number needed to treat or something? But how much is the potential benefit for patients for this drug?
So this is the Maestro-NASH trial. It included 966 patients randomized to 2 doses of resmetirom, 80 milligrams, 100 milligrams versus placebo. We had 2 endpoints, primary endpoints. NASH resolution, and just briefly, I'll mention the high dose, 100 milligrams. There was NASH resolution or MASH resolution in 30% with the high dose, 100 milligrams, compared to 10% with placebo, so about 20% delta from placebo. And then when it came to fibrosis regression by 1 stage, with the high dose, it was around 26%, and the placebo response rate was 14%, so 12% delta. Now, as Dr. Francque said, this is a high barrier. It hasn't been easy to actually meet these endpoints, and the fact that resmetirom met both primary endpoints is a big deal. Because we are talking about MASH resolution, which requires having no ballooning on the repeat liver biopsy, or fibrosis regression by 1 stage when we only have 4 stages. So to go from stage 3 to stage 2 is definitely a big deal for our patients. And we had more patients with F3 actually included in the study than F2. So this was a more advanced population. So in my mind, this is a good effect size. It may change the natural history of the disease, but of course, we are eagerly awaiting the final results from the Maestro-NASH trial, where we're going to do a liver biopsy after 54 months of treatment, and then look at how many patients progress to cirrhosis as one of the endpoints, look at what we call major adverse liver outcomes, such as development of ascites, variceal bleeding, encephalopathy, and then we will get to hopefully full approval of resmetirom, because today it is still conditionally approved by the FDA based on surrogate, which are NASH resolution or MASH resolution and fibrosis regression.
Oh, very good. So that's actually quite impressive. You had either an absolute risk reduction of 20% if you do for NASH resolution, or fibrosis 10%. That will then convert to a number needed to treat of 5 or 10, which is actually not bad. Again, in a relatively short period. And I think that impressed many of us, that there was actually an effect on fibrosis also. But what about side effects, Sven? Okay, this drug is how does the drug actually work? Can you explain that very briefly, and then maybe move on to what are the potential side effects or known side effects for this one?
Well, one of the main mechanisms of action has to do with improving mitochondrial health and mitochondrial function in the hepatocytes. That's one of the main mechanisms of action. Just before answering your question, Aleksander, I would like to come back to what Naim said about the effect size, and the 10% fibrosis regression may not look extremely impressive, although it's a big advantage. But we are here really looking at fibrosis regression, and what is probably clinically as meaningful is that we are halting disease progression. And for the F3s, then we are taking into account as an endpoint the absence of progression to cirrhosis. So there we are talking about progression, whereas for the non-cirrhotic ones, we require regression of fibrosis. And if you take the whole picture of those that progress, those that are stable, those that regress, then you see that the drug also provides a protection against progression. So there are a number of patients that do not progress, and that is also something that we need to take into account to assess.
So you would actually add that
potential
to understanding of the clinical efficacy, that stable disease, if you're in asymptomatic state, is actually also an advantage. Now, I think I buy that, but the regulators don't buy that.
No. Well,
yes.
It's about setting the endpoint for approval and then go to the clinical advantages, which are more than hitting a high barrier for approval. So it's a different concept. In terms of sorry?
Yeah, but with the side effects there, so you say it improves mitochondrial function and it reverts intrahepatic hypothyroidism. Yeah. But what about the side effects related to this? There seems to be a hormonal axis there. What does that mean?
Well, there is some debate about what the meaning is about the impact there might be on the hormonal axis, and also some effects, even if it's mainly liver centers, it's not perfectly liver specific. So there might be side effects on the long run. We still have to we still have to wait for that. But with the data we have so far, also from other trials, because it's not just the phase 3 trial, we have safety data on. There's of course all the other trials in which resmetirom have already been used. And to date, the safety profile looks very good. There is, of course, as we can see with many other drugs, there was a case of elevated liver enzymes that we need to be careful for. That's why that's also in the label. We will have to look on the long run still whether there is an impact on the bone and whether there is some impact on the general thyroid axis. But so far, besides some mild side effects, safety and tolerability seem to be very good. But of course,
roughly how many has been treated? How many has been treated? How many patients has been treated so far? We had almost thousands in the Maestro, but how many patients in total at the moment?
I should look at Naim probably to have a more precise
roughly
figure.
3,000 or what is the number? Something like that, or
yeah, but that's one of the things that Stephen has really done very well, also in collaboration with the Madrigal team, who really wanted to have robust data. They initiated several parallel studies, also non-invasive tests, etc., that not only serve the specific purpose of that, but also make us having a very rich data set with, but I don't know the exact number.
No, it was just that this is a significant number, and I think
that's far more than just the phase 3 trial data.
Okay, let's move a little bit on because I want to go forward, and Naim, you're already using it, but here, just because when we discuss the effect, back to you, Amalia, as you say that for many of these, yes, they are at liver-rated list, but they also have high cardiovascular risk. You said there was something about the lipids. What about type 2 diabetes and obesity, which is an effect? Is there any effect there, and how do you see that?
Well, from what I've seen that has published, and probably Naim knows more since he was part of the team that wrote the manuscript, I saw that they had similar effects in subject with or without diabetes, but the effects on glucose control is considered neutral. So there is no effect, no bad, no worse, no good, no bad. And so this is something that is really related to lipid metabolism. And this is quite interesting because that means that for the resolution of NASH, we know that the diabetic patients have a higher risk to develop MASH and advanced fibrosis, and the prevalence of the disease is higher in subjects with diabetes. But the result of this trial says that you don't have to control glucose to improve the fibrosis. So that probably the two pathways, the lipids and the glucose, are parallel. And
what about weight? What about weight? How does it affect weight?
I don't know, Naim, maybe you are.
I think it's weight neutral also, isn't it?
Yeah.
No, it was again, how do we see clinically? We could come back to how we treat it, but I guess that also means that this is a very much liver-centered treatment, and we should then, the rest of the cardiometabolic risk will still need to be targeted, I think, individually until we know more.
Well, we know the liver is central for the production of the lipoprotein that are the main factors for atherosclerosis and the cardiovascular disease. So you're right. This is liver center, is lipid center, but it's.
But you put your money on. We will come back when it's done, Amalia. You'll put your money on improved cardiovascular risk, or
no, I mean let's say that I put my money because the risk factor for cardiovascular disease are improved. There are less the reduction of the risk of the cardiovascular risk factors. So that is where it comes from. But we'll see later in the discussion.
Okay. Maybe a quick one here for you, Sven, before I go back to Naim. So we changed the nomenclature almost a year ago. But this drug was developed in the NASH NAFLD era. Now we call it something else. How does that work? Can we still call these patients MASH and MASLD patient and treat them according to this, or how is it?
Yeah, the inclusion criteria for the trial specified also the need for the presence of components of the metabolic syndrome. So by definition, the patients included in the Maestro NASH trial, I think they all met also the MASH criteria. So in that sense, it doesn't change anything. The question is rather a little bit the other way around. If we have the classical NASH patient that does not meet the MASH criteria, which is a small proportion of the patient, drug like work in these patients will probably depend on the underlying mechanisms that we do not know, but most probably it will also work at least in part of these patients, but we don't know. But for the time being, the patients that have been treated were all meeting also the new MASH nomenclature definition.
Well, that's very good. So Naim, you're probably the man in the world in outside clinical trials who treated most patients. So can you tell us, do you want to tell how many you treated so far? Just so we know this is actually the guy who knows what he's talking about. How many have you treated, or do you have on treatment at the moment?
Yeah, of course. So I've been, working with Resmetirom since 2017 in the context of clinical trials. But since, FDA approval on March 14th, I've done about 50 prescriptions. And actually, many of them went through insurance. So this is encouraging, although this is what we call the honeymoon phase in the United States. And I think some restrictions will come along in the next few months. However, I haven't seen
I just want to pick stop. So now I think we've convinced people you know actually what you're talking about. Then I want to actually go into what is the perfect patients who are most likely to benefit from resmetirom.
Yeah, so I want to make two quick points before I get into this. The first one about adverse events, and the two adverse events that were more common in the resmetirom arms compared to placebo were diarrhea, which is mild. Usually it starts within a week or two and it lasts a couple weeks. And the second one is nausea, which happens in about 20% of patients. Same thing, within a week or two and usually lasts a couple weeks. And discontinuation rate because of adverse event was very low due to nausea or diarrhea. So these are the two adverse events that I discuss with my patients even before they start resmetirom. The other point.
That's a very important point again. So you inform them that these are the key side effects, nausea, diarrhea. They usually appear in whatever 10 to 20% and disappear in a couple of weeks. Now that's very useful knowledge.
Yes. And the other thing is, with the new nomenclature, now we have data from Asia, from Europe, and the United States showing almost complete overlap between the MASLD and NAFLD populations. So that gives me confidence that I'm treating the right patients with using the new definition for MASLD. The question was about who is the appropriate patient for
the ideal. No, let's start with the ideal patients. Who is the perfect? And then I want to work a little bit forward to see how do we define that in terms of biomarker. But just in your view, what is so everybody in their mind can see, okay, this is the patient that I know very well from my clinic.
Of course, the label says that, this is indicated for patients with MASH and F2 and F3 fibrosis. So non-cirrhotics, definitely no decompensated liver disease. However, the trial was based on histology, liver biopsy. So how can we identify these ideal patients without a biopsy? Now, in the FDA label, there was actually a nice table that shared some NIT data, including VCTE liver stiffness. And if you look at the median, it was 12 kilopascals, and the range was between 10 to 15. And then they also included data on ELF, enhanced liver fibrosis, and the median was at 9.7, and the range was between 9.2 to 10.4. So we are actually working with an ASLD to develop criteria for treatment, and I'm happy to share. But we divided patients into ideal, what we call the green zone. We have patients that are not suitable. This is what we call the red zone. And then we have the yellow zone, which are patients that can be borderline, so you have to be careful, and happy to go into details.
Let's follow up on that in a bit. So you would say, for your perspective, compensated F3 patients with MASH would be the ideal one with risk of progression. Then let's go back to how we define that, because then we need to open the discussion about the biomarker cutoffs. And I think that's something we need to work a little bit around on, and I think probably also see, can we agree? And I'm sure ASLD got a very good suggestion for that. But one thing I want to pick on before, because now we got the patients, we got the resmetirom, but it was approved together with diet and exercise, Amalia, how good are liver doctors at prescribing diet and exercise?
Well, as you know, I'm not a doctor. I think the question should be how good are the patient to follow indication for diet and exercise? Because I think the doctor could be very, very good, but sometimes, you know, there's not enough to motivate the patient. I think it's very difficult to find the right lifestyle change for these patients. And as soon as they have a drug, they usually, and the pills, they usually are less inclined to follow a dietary regimen. Of course, you know, it's very important, the motivation from the doctors to say that since this is a drug that it doesn't change their glucose profile, especially they are, you know, pre-diabetic or diabetic, and since it doesn't have an effect on the weight, it's very important for the liver to change the dietary pattern to decrease, you know, sugars, to decrease saturated fat, to have a healthy diet, and of course to have exercise and to have a movement and to have a sort of exercise. This is the basic, and this is what they have been told before any drug. Right now, that will, I think, speed up their recovery, because we have seen that the percentage of subjects was limited. But of course, you know, if you help the liver to reduce the fat with the diet and exercise, I think the drug will be more effective.
Yeah, so the drug will be most likely more effective if it's followed by lifestyle changes.
An add-on. It could be synergistic. We don't know, but it's for sure is an add-on.
Yeah, so it makes good sense. So Sven, how do you see it? Again, I can tell for myself, yes, we have it, we advised it, but I'm not sure many places have any good programs for that. How do you do it?
Well, that's the main hurdle. Then, I mean, society is investing still a lot of money to solve the problems once they are there, instead of preventing the problems. And so there is very little support, reimbursement, help for the patients to do all that lifestyle modification. So we try with the program and advice, but it's difficult because it all costs money and the patient has to pay it himself. Also, going out for shopping and buying healthy food is not that easy. It's expensive. Going out and move around, if you are living with obesity and have articular problems, is also not that easy. So it's easily said, but not easily done. And I think we should, in the end, hope that some of the investments we do in terms of money will more shift towards support for that than to treat the problems once they are fully.
Yeah.
But that's world and ideal patient.
So Naim, what do you do with your patients in the US, and how does that go with the reimbursement?
We are learning because this is relatively new. We're 2 months in. But as I said, you know, a few patients were approved. Recently, the VA system released their guidelines on how to approve resmetirom. Unfortunately, they mentioned that you need to have a liver biopsy within 3 years before you start treatment that is showing MASH with F2, F3. I don't think this is a good strategy, because if you're going to select patients based on biopsy, then maybe you have to do another biopsy to assess for response at 1 year, and then, you know, do you do another one at 3 or 4 years? I think this would be too many.
Get back to that. I just wanted to your view on diet and exercise. How do you prescribe that when you do the drug, and how do you inform the patients? How do you get this alliance working?
You know, it's not an easy thing to, do a comprehensive lifestyle intervention because as you heard from the other speakers, it's easier said than done, and sometimes there's no reimbursement. However, I try to rely on digital therapeutics, digital tools. I've had good success with apps like the Naim app, if the patient is able to afford it. We worked also with another digital therapeutic called Aspire RX, which has FDA approval for patients with type 2 diabetes. We've created material also in our clinic, so a booklet that has different recipes, and we actually developed content for Mediterranean diet, for ketogenic diets, intermittent fasting, and a plant-based vegan diet. So we hand this to our patients. Unfortunately, there are time constraints and financial issues that will limit our, success with the lifestyle intervention. But
But you still got a system that's kind of impressive. That I think that's the kind of thing we should do, and probably also see in societies. How can we actually try to develop some kind of guideline help to make it easier for people to do it? We don't have that much time to left. So what I want to dig into now is to see again identifying the appropriate patients. So I guess the target is we don't want patients with cirrhosis because that's not indication yet. And I think we should not have them too early because then there are probably not so much benefit. But yeah, I don't know who wanna open there, Sven. So what is, in your view, the ideal patient that should be treated with resmetirom?
I'll go first if you guys don't mind.
Oh,
This
that's
is
okay.
a topic dear to my heart, but here's how I see it. So the green zone, the ideal patient would be someone with, on VCTE with the CAP score more than 280. This is what was used as a pre-screening strategy in the Maestro NASH trial. And then liver stiffness between 10 to 15. And that would be the criteria on VCTE. If you're going to use ELF, probably an ELF between 9.2 to 10.4. This is based on the Maestro NASH trial. If you're going to use MR elastography, then maybe between 3.3 to 4.2 kilopascal. I think these are good candidates.
Let me challenge you a little bit there. No, I think these are, it kind of makes sense. Yet, of course, there is some spectrum bias to the studied population relatively to what will maybe in my clinic. So first, maybe would you go for one test alone, or would you have two concordant tests? Normally if you have two tests, then they're much more precise, or your risk of actually have false positives. And I think we don't want to have too many false positives, have that treatment that is quite expensive and long-term. So how do you do it there?
No, I couldn't agree more. Yeah, I mean, the positive predictive value, unfortunately, is not ideal for many of these tests. And also we have, this variation coefficient with FibroScan, so you can get slightly different values. So I think I feel more comfortable if I have two concordant NITs, especially if one is serologic, one is based on imaging. But the practicality becomes an issue, insurance coverage becomes an issue. So these are things we keep into consideration. Just to get back into patients that I would not treat with resmetirom, I would say if the liver stiffness is more than 20 kilopascals, probably this is a cirrhotic patient. If the ELF is more than 11.3, and if the MRE is more than 5. And now we have this
yellow. I just hold you just a second there, Sven. Do you agree with these cutoffs? With 20 for TE and ELF of 11.3, I think it's really important to have the ceiling.
Yeah, I do. I think, especially for ELF, I think it's for sure correct. 20 for VCTE might be high, but as Naim said, there's a high coefficient of variability. So there I would definitely go for a second measurement and take the mean just to make sure that you have those levels. Yeah.
Okay, so another thing there, which I think is still, I think we all want to get away from the liver biopsies. That's clear for the patients for many things. But the issue is still, we will miss out on inflammation. So these biomarkers are very good at finding fibrosis. And I think if they're too concordant, we have one of these cutoff we discussed. But what about inflammation? How do we manage that not knowing about inflammation? It's a difficult one.
It's still an issue. It's clear that we need to do better in terms of biomarkers. But we have now some biomarkers in development that identify at-risk MASH where you have both the MASH and fibrosis component, and they are not perfect. None of these biomarkers is perfect, as Naim already said. But I think we are step by step getting there. And I think the FDA was smart by saying it needs to be NASH with fibrosis consistent with F2, F3, meaning that they do not express how it needs to be diagnosed. And once we come up with something that is at least as accurate as the biopsy, I think it's where we need to go. So I think we are evolving in that direction. We should also not forget that inflammation and fibrosis are tightly linked. So it's not abnormal that with fibrosis markers, you also capture some inflammation and vice versa.
So Amalia, treatment like these, how long should they be treated? Does this...
Well, before answering this, I have a question for Naim. Since this is targeting the thyroid receptors, do you measure thyroid hormones before giving the therapy? And do you think there is there was difference among those that were on thyroid hormone replacement or not? And because this will be very important also to answer your question, Aleksander, are these things, are there some other things we should take into consideration for the length and not only looking at the liver, but also at all the effects that this drug has?
That's an excellent question. So in the Maestro NASH, about 15% of patients were on Synthroid, thyroid replacement therapy, and they did really well. There was no signal that we have to make major adjustments. Overall, there was minor changes in free T4, but no significant effect on the active hormone of T3 or TSH, which is reassuring. However, again, we have about 2,000 patients that were looked at for the safety data, and we are clinicians. So I think in patients with hypothyroidism, my approach is going to be that, yes, I will measure the thyroid hormones at baseline, and I would, monitor with the primary care physician probably every 6 months to make sure that, there is no new signal that was not picked up in the phase 3 trials. The other thing is there's also an increase in sex hormone binding globulin, and this was actually used as a way to assess for target engagement. There's no effect on free testosterone that we picked in the phase 3 trial, but this is something to keep in mind. And I'm still debating if I will do this routinely in my patients or do I do it in selected cases. But these are two areas that we need to pay attention to and, keep in mind even post-marketing.
That's good. We have then something to follow up because we are running a little bit out of time, and I'm sure there's a lot to learn, but I've certainly also got some very good practical advice here. I think coming to an end now, this was celebrating the first drug actually on the market. But if you can all come very briefly, how do you see or wish for this landscape around drugs in, say, a 5 years or later period? What is the dream scenario for this, Sven? Brief and sharp.
The dream scenario is that, first of all, we identify the patients that after lifestyle modifications still require specific liver-targeted treatment. And that second, while we take the whole picture of halting disease progression into account, we come up with other drugs that can help people that are non-responders also to resmetirom, because they also exist. So we need anyhow additional tools to...
More things on the shelf and more to choose between. Amalia, what is your wish for a perfect?
Well, I think that what we will need to know in the next future is the interaction of this drug with the anti-diabetic drug, because most of the patients will be diabetic and will need extra medication, or they are already on a medication. So that will be interesting to know if there are drugs that counteract the effect or they improve the effect of this drug. That I think this is what is needed to know, because first, the patient do not want to take too many drugs. So for example, if some they are on statins, but if the effect on cholesterol will be already enough, maybe they could, just use one drug. These are the questions, in my opinion, for the next future.
Wonderful. You are last, and then I will close, Naim.
Well, I am a dreamer, so I think a lot about the dream scenario, and I think I would like to see better efficacy on the hepatic endpoint, so maybe higher MASH resolution rate, higher fibrosis regression rate. Hopefully we get into the 75–80%. I would like to see a beneficial effect on weight, glycemic control, and lipids. And most importantly, I would like to hopefully have data on changing the natural history of the disease and decreasing the incidence of major adverse liver outcomes. That would be the holy grail for me.
I think we should always wish or aim for the holy grail, and I guess the clinical endpoint points will be fantastic. At that time, then you can also establish through surrogate markers that will allow us then to do quicker trials, etc. No, but then I want to thank you very much for this discussion. It has been very, very interesting. I'm sure we will come back to this as more things happen and we learn more. And then I'd like to close the EASL Studio, but also remind you that in the upcoming episodes, other colleagues from the field will share their knowledge about endohepatology, how advanced endoscopic techniques can help transform hepatology also. And as always, remember to join EASL, become part of the family.